This presentation is on accessory ossicles versus avulsion fractures versus stress fractures. How can you tell? My name is Mary Lloyd Ireland. I'm an orthopedic surgeon at the University of Kentucky, and this is based on my cases and ones that I've been exposed to that have made me be able to tell what's a fracture, avulsion fracture, or a stress fracture. By definition, stress fracture occurs from repetitive microtrauma, and the forces exceed the ultimate stress of the bone, cortical or cancellous. The failure can be on the tensile side versus the compression side. Typically, the ones that don't heal are on the tensile side of the bone, such as anterior tibia, the dreaded black line, the Jones fracture, lateral aspect of the fifth metatarsal. And there is a high risk of nonunion on the tensile side. Also, if it's an intra-articular fracture, such as a medial malleolus fracture, or a predominantly cancellous fracture, such as a navicular fracture. These are the high risk of nonunion and should be diagnosed early and followed with appropriate imaging. The fatigue fractures are a repetitive approach of stress to normal bone versus insufficient application of stress to abnormal bone. So assessment of the patient's bone density, their bone health by certain imaging is necessary, and also to rule out female athlete triad if there is a stress fracture that appears to be on abnormal bone. Stress fractures, the foot morphology is very important in this. In a pes cavus foot, we see more bone problems, stress fractures, more peroneal tendon problems. In a pes planus shaped foot, flat-footed, there are more posterior tibialis tendon problems because the posterior tib has to try to recreate the arch that the person doesn't have. So you have overuse of posterior tibial tendon. Typically not a rupture, but overuse. An example of pes planus with hallux valgus. The valgus, or the bunion deformity that you'll see in the medial aspect of the first metatarsal, is a bump, but it's not a fracture. The valgus really isn't the painful part of the bunion deformity. It's more the rotation of the great toe or pronation of the toe. So oftentimes valgus isn't as much the problem as it is the pronation or the supination. And then this is the valgus from the back of the alignment of the calcaneus to the ankle in pes planus. When you look at somebody with flat-footedness, you see more toes laterally, and this should be symmetrical. The great thing about orthopedics is we usually have a good to compare to, so look at the normal and then go to the less normal. If you have posterior tibialis problems such as dysfunction or a sprain of that, you'll see too many toes. This is seen on the right foot here where you see 4 toes, and that's because the posterior tibialis tendon is not inverting and creating the normal arch. So look at the back, have them go up on their toes, ball of their feet, and rock back and look for symmetry. Physical exam of the foot and ankle. You can palpate everything about the foot and ankle. So if you know the anatomy, you can figure out what's going on. The base of the second metatarsal can have metatarsalgia in a volleyball athlete, particularly in somebody that has a Morton's foot, which is a long second metatarsal. Ask the patient to use their intrinsic and spread their toes. If you have that bunion deformity, they won't be able to do as he can to move his great toe medially. We put a lot of feet in very compressive shoes, shock absorption shoes, and that's one of the reasons that we have stress fractures, because we can't really feel the earth, so to speak. There is more and more now talked about with minimalist shoes. When assessing the lesser toes, an important difference is a claw toe versus a hammer toe. This shows a claw toe of the foot on the upper diagram. So if the PIP and DIP are flexed, think about a neurologic involvement. In a hammer toe, as shown on the bottom drawing, there is flexion of the proximal interphalangeal joint, but extension of the distal. So think about shoe wear in this situation. Think about that hallux valgus or bunion deformity where the great toe moves laterally and is pronated, which shoves the second toe out of the way. So you can have dorsal calluses here, but think about something neurologic. If you see claw toes of numerous toes, if there is a very high arch, think about Charcot-Marie tooth disease. And you got to look at the feet, examine the feet. Freiberg's infraction is shown here radiographically. This can sometimes be treated surgically with reshaping of the second metatarsal. This is what was done in this basketball coach who was symptomatic. You can see her deformity of the second metatarsal there, and this is what Freiberg's infraction looks like, described by an orthopedist from Cincinnati, Ohio, Freiberg. Stress fractures, there are specific risk factors: sports, hormonal imbalance, malalignment, foot development, that rigid high arch, less muscle mass, nutritional deficiencies, surfaces that are hard, uneven, or a new surface, and training intensity. So if you're having to evaluate someone with pain in their foot, you need to make sure you understand what activities they're doing. Have they had a change in shoe wear recently? And obviously examine their feet. Risk factors also are gender related: menstrual disturbances, caloric restriction, lower bone density, muscle weakness, leg length differences. Usually the longer leg is the problem. Lower fat diet. This is based on work in sports medicine and the American Journal of Sports Medicine. Stress fractures of the foot and ankle. This is the rough incidence of these. 50% involve the metatarsals. The most common metatarsal fracture is the second, followed by the third, then the fifth, then the first. The lateral malleolus is much more common than the medial malleolus. Fracture of the os calcis, 10% in this series. So the vast majority of fractures are in the metatarsals. Sesamoid fractures can occur. You can also have a bipartite sesamoid. Differentiating these two, similar to a bipartite patella, is the appearance by radiographs, and also workup can be done with bone scan or MRI scan. The high-risk side of the bone is the tensile side. So here on the lateral aspect of the fifth metatarsal, this is a classic Jones fracture. You can see how thick the cortex is. So the bone's trying to heal, but just cannot heal because it's on the tensile side. The superior aspect of the femoral neck is the tensile side. This shows a stress fracture of the inferior aspect, which is the compression side, the good side, or the less risky side. And this is the dreaded anterior tibial stress fracture, dreaded black line, common in basketball athletes, a very thick cortex. So these two are treated with intramedullary screw or rod. Don't do anything to the fracture, they'll heal. In this situation, if this fracture was started up here superiorly, it is at risk to displace, and early intervention with fixing this operatively should be done if it's on that tensile side. Remember, the tensile side is the high-risk side. The low-risk side is the compression side. As in the second, third, or fourth metatarsals, they'll go ahead and heal. This is a healing second metatarsal stress fracture. This is that healing compression side, keep them non-weight bearing, and then the fibula will also heal. Medial side of the tibia is also compression side. The entire fibula is pretty much compression side. So locations of concern with stress fracture are the anterior tibial cortex, medial malleolus, navicular, proximal fifth metatarsal, or Jones fracture. So early diagnosis and surgical intervention are necessary oftentimes in these locations, tensile side. Non-critical or less critical, these will heal. Metatarsals 1 through 4, the fibula, os calcis, talus. This is an example of a second metatarsal stress fracture. This is at 6 weeks, so you can see how that looks much different. Clinically, you can palpate callus, and they may be sore there, but that's where you want to palpate, right in the second metatarsal diaphysis. So this is the original x-rays. We didn't get any other imaging because this was clearly a stress fracture, so that's the diagnosis. And then this is as it's healing. So it takes a few months for it to heal. Further workup in the individual would be why this stress fracture occurred. Was it related to intensity of training, shoe wear, having female athlete triad? This is an example of a fibular stress fracture in a basketball athlete. You can see the big wad of callus in the fibula. The fibula is a very interesting bone, and it seems mostly cortical with very little cancellous bone, and perhaps this is loaded abnormally because the fibula anatomically was longer, or it oftentimes these fibular stress fractures happen in a jumping sport like a gymnast or basketball. This is a track athlete that came in, long distance runner, with pain in her left hip. These are her plain x-rays, so I would be more aggressive in working up individuals with groin pain with plain x-rays, and the next step would be an MRI scan. In this case, we did a bone scan. This individual continued to have pain. A bone scan was done, and clearly there's increased activity in the medial aspect, or that compression side, and she ended up healing with non-operative management. It took her a while to heal. She did have female athlete triad, so that had to be addressed as well. This runner had lateral knee pain. You can see here where the arrows are. There's a vertical abnormality in the patella. Doesn't appear to be a bipartite patella, and his bone scan was hot. This is a fracture that healed with relative rest, and his bone health was normal. He had been doing more intensity and more hills. So stress fracture diagnosed first by clinical exam, and get x-rays, back him down for a long enough period of time, assess his mechanics so we don't have a recurrent injury. Does not need to have a patellar fixation. This case is an 18-year-old freshman who was forced to wear certain shoes that she wasn't used to. She complained of midfoot pain of both feet, more left than right. I asked her about her having normal periods, which she stated she did. You really have to ask further than do you have normal periods, because her definition of normal was menstruating 2 months out of the year when she wasn't playing basketball. So she thought she shouldn't be menstruating when she was playing basketball. So she did have a female athlete triad issue. The plain x-rays did show the fracture, as you can see with the arrow. The navicular in the foot is like the navicular in the wrist, in that the blood supply comes from distal to proximal, and that is also a risk factor why this doesn't heal. Dr. Joseph Torg described this external rotation 30-degree navicular view that shows the navicular much better and will show a fracture. So if you suspect a athlete or patient has a navicular fracture, make sure that you get this externally rotated views and also get a comparison. And this is the typical orientation of the navicular stress fracture, perpendicular to the body of the navicular. Image these early. This is the CT scan. This patient had more pain in her left foot. And if you look at the CT scan, this propagates all the way to the plantar aspect of the navicular, not quite all the way through on the right. This is her bone scan that was very hot bilaterally. This is the lateral bone scan that shows increased navicular activity bilaterally. She was having more symptoms on the left, so that's what we did internal fixation of. And this is her x-ray. Local bone graft was done, 1 screw, and you can see here where she's healed. Fortunately, the other side healed. She was in a wheelchair for a while, did well in school. Her freshman first semester fall, didn't play for that year. She ended up doing okay. So image early with midfoot pain to rule out a navicular stress fracture. Fifth metatarsal base fractures. There are different classifications of these. Acute, displaced or non-displaced. Previous injury abnormality type 2, a styloid process fracture. Fifth metatarsal cuboid involvement. Fifth metatarsal and cuboid involvement. This is a 9-year-old very active boy who does all sports. He kept on breaking his cast, so he was seen by me to potentially perform surgery. My concern is this 9-year-old breaking his cast. He also would probably not do well after surgery. He was seen for continued pain. This is what his x-ray looked like. You can see here, this is the apophysis of the proximal fifth metatarsal. So that's a normal growth. The apophysis, or an offshoot, where the peroneal brevis is attaching. But here's where his fracture is. So you can see there, it looks like a Jones fracture, but in a 9-year-old, this should heal. Counseled the patient and family that he can't be breaking his casts, and he did heal. This is a college freshman football athlete, refracture, non-union fifth metatarsal. This is his original x-ray. You can see how thick this cortex is. So this is treated with intramedullary screw fixation. This is 2.5 months post-op. You can see where the fracture line, you can see it, but it's almost gone. So this is healing. It takes these a while to heal. Usually we leave the screw in. And this is 2 years post-op. You can see such a small canal, medullary canal in this fifth metatarsal, and still a very thick cortex. This individual had pain in his heel. This is a very interesting football athlete who was a diabetic linebacker, kept on having pain in his heel. And if you look here, this is ectopic bone in the plantar fascia. It was still hot by x-ray, by MRI scan. It looked pretty mature by plain x-ray, but he was really literally walking on a stone bruise, or a stone, a chunk of bone, and so he underwent excision of this. This is an unusual thing, but do get an x-ray to rule out any type of problem with the calcaneus itself or the plantar fascia. This is what he looked like at the time of the excision. Pretty normal exam. And then this is what the pieces look like when they were excised, and then the new lateral radiograph. And he did very well after excision of this, no recurrent of ectopic bone. 15-year-old football athlete doing a lot of running on hard ground. It hadn't rained lately. He complained of heel pain when he walked or ran. This is his lateral view. This is his almost closed calcaneal apophysis here. And you can see the trabecula of the calcaneus. But then when you look here, this is a healing stress fracture. So a lateral view is very important to obtain if patients have continued heel pain. Healed uneventfully with relative rest and not running for a couple of months. What about Sever's disease? This is called calcaneal apophysitis, and so the apophysis onto which the Achilles attaches is the calcaneal apophysis. We see this problem with repetitive microtrauma. Radiographs are usually symmetrical. There is sclerosis of the apophysis sometime, and oftentimes there is multi-center ossification of that apophysis. These are lateral radiographs of soccer athletes with heel pain. The individual on the top is younger than the one on the bottom, but you can see the varied appearance of the calcaneal apophysis. This is where the Achilles tendon inserts, similar to Osgood-Schlatters disease of the knee, where the tibial tuberosity is painful. The calcaneal apophysis can also be painful. We see it oftentimes in soccer athletes. Usually it's girls around age 8 and boys around age 10. This is treated with modification of shoe wear, using cross trainers, better shock absorption of the medial aspect of the foot, and stretching of the Achilles, and overall balance program. This will improve, doesn't need surgery, and if you really want to tell somebody what the future holds, tell these individuals that in about 3 or 4 years they will develop Osgood-Schlatters disease. Typically it's in tight structured individuals. Accessory ossicles have specific names. The os peroneum is in the tendon at the cuboid level. The os versalinum is present in the peroneus brevis more distally and is present in 15%, usually bilateral. This is a diagram of all the many ossicles that we see in the foot. And the two that I just mentioned were this one, os peroneum, and this one is the os versalinum. These can be mistaken for fractures. So if you have somebody that has what looks like an ossicle, or you're not sure if it's a fracture, it's important to go to textbooks like this by Keats and Atlas of Normal Rentgenogram Variants to look at these and also get a comparison view, because oftentimes these are bilateral. This is an example of a symptomatic os versalinum, so the peroneus brevis inserts right here. And if you think about the sport of basketball where they're changing direction, doing a lot of things, that peroneus brevis is pulling on this, so then you develop a stress fracture here, but this isn't anything that can be excised. So this is more of an ossicle problem. Don't try to fix this. This is an ossicle problem. So if you think about a stress fracture, that would be a Jones fracture here. And so this is an accessory ossicle that can be removed successfully. And he had one that became symptomatic, and then the other one became symptomatic. So you can see here where there's more of a distance here, and you can't fix this because it is an ossicle. If you try to fix it, it won't be successful. So keep the peroneus brevis intact and just whittle out or remove that piece of bone. And this is his post-op course. This is what an os peroneum looks like. Again, not a fracture. So your os versalinum is here, your os peroneum is here, but you could think that that is a fracture off of the cuboid, and it's not. What about the medial malleolus? This 9-year-old female cheerleader had been having left ankle pain for a couple of months. She fell from a stunt, and she had a localized bump in the medial aspect of her left ankle. If you look at her x-rays, her epiphyseal plates are open. Her right ankle has a little more prominence here, but you don't see a lucency. And so over here, where she was symptomatic, she did have a little radiolucency. So we felt this was a medial malleolar accessory ossification center, and she was treated non-operatively, and follow-up x-rays showed this to go ahead and fuse. So again, not a fracture. It's an accessory ossicle with a deltoid pulling on it in a gymnastic sport. It'll heal without surgery. This individual, basketball athlete, went up for a jump shot, felt a pop, sudden onset of pain, medial aspect of the ankle. These are his original films. He denied any pain, but it looked like this was probably a stress fracture of the ankle that does communicate intra-articularly, so if there's synovial fluid bathing this, this may go on to a non-union. Continue to have pain, and we did a fixation of this. Didn't take this down at all, but you put compression across this fracture and it will heal. Had no symptoms after that. This is 2 weeks after his fixation, and this is 2 months after his ORIF of his medial malleolus. This is a radiograph from a basketball athlete who had a green stick fracture, buccal fracture of the fibula, and you can see a displaced fracture of the medial malleolus. This is one, again, that's concerned for non-union because there's a gap in this, synovial fluid bathing this, and this is a Salter 4, and this is a green stick that didn't involve the growth plate, but you can see here where there is angular deformity. He was treated in a cast, came back. I didn't see him initially, but he came back and had basically a non-union of this. The fibula fortunately healed and got straight. 4 months after his injury, he was continuing to have pain. You can push on the medial malleolus. You can actually move the medial malleolus. So the diagnosis was made by clinical exam and x-ray, and this is what his medial malleolus looked like at the time of surgery. So basically, make an incision, take the non-union down, do local bone graft, and fix this, and he healed very, very quickly. So this is the operative fixation. Here's the non-union here. Put it back, and then this is the screw that's fixing it. Post-op x-rays. He came back a couple of months after his surgery and had completely healed and was doing fine. Continuing on patients with medial ankle pain, much more common to have an ankle sprain, most common injury that we see in sports, and lateral pain. This individual had left ankle pain for about 3 weeks. He was overweight and out of shape and wanted to get back into better condition, so he started playing basketball, and we thought he may have a stress fracture of his medial malleolus. This is his x-ray. Now, 3 weeks after his original complaint, we put him in a boot. He didn't come back initially, but when he did come back at 3 months, he still had pain, so we did a bone scan. And you can see here where there is intense increased activity in this bone scan of his left ankle diffusely. He was lost again. 5 months after his original presentation, he has a permeative radiolucency of his medial malleolus. There's a little periosteal reaction here. This is what we're concerned about. This is his MRI scan. And if you look at this medial malleolus, again, there's a permeative lesion. This is the cortex of the medial tibia. This doesn't really go into the joint, but of concern because of the expanding size of it and the fact that there really aren't any boundaries. He had a biopsy and had a small blue cell tumor, was seen by tumor service in another state, and was diagnosed as Ewing sarcoma versus lymphoma. So beware persistent medial pain, get appropriate imaging. Not all ankle injuries are sprains, particularly if they don't have a specific injury. So make sure you can see them back. Unfortunately, we didn't see this individual back as we had told him to come back. So sometime they're lost to follow-up. But if you worry about them and lose sleep over certain individuals, then you ought to call them up and get them back in. You may not have seen it, but it has seen you. And this is the first medial malleolus tumor I've seen. It may not be the last. So based on these cases, hopefully you can know the differences of ossicles versus stress fractures based on the physical exam, history, and also the plain radiographic appearance. Don't jump to other imaging unless it's needed. For a bone problem, typically it's a CT scan, but the MRI scan can show bone edema acutely and help identify an ossicle from a stress fracture or a fracture. get good plain radiographs first. Oftentimes get a radiograph with some type of a metal marking and see if that correlates exactly where the patient's pain is. Thank you very much for your attention.